We're going to start with some basic principles here, and the first principle we're going to look at is drug permeation. And permeation, of course, refers to the ability of a drug to move within the body. There are several factors that influence drug permeation, and you see those listed on the slide. I'm going to highlight two of those for you here. Lipid solubility is a very important factor for drug movement in the body. In fact, the ability to diffuse really relates to that particular property. So many drugs are designed to be lipid soluble. The second property here is concentration gradient. Of course, the movement of drugs in the body is very much influenced down its concentration gradient. Most drugs are going to move passively in the body. We will talk about the concept of ionization very shortly, but the fact is that only the free or the unionized form of the drug can contribute to that concentration gradient. Now, surface area and vascularity are also important, but a little lesser so than the first two factors we've just talked about. When it comes to surface area, how about an example? The example here would be stomach versus small intestine, and I'm thinking now about drug absorption. If you had to predict the absorption of a drug just simply based on surface area, you could easily tell that drugs are more likely to be absorbed in the small intestine, just simply based off of the larger surface area with all the microvilli found in the small intestine. Vascularity is also an important factor simply because it is going to influence the movement of the drug. The more vascular the tissue, the greater the movement of that particular drug. And you might think of an example related to routes of administration. For example, if you were to inject a drug intramuscular and compare that to injecting that same drug subcutaneously into the fat, you know that muscles are a more vascular tissue, and so the chances are that the drug is going to be absorbed much faster by the intramuscular route. And you might take a segue here to a situation such as shock, where you've got reduced blood flow, and that's going to influence the movement of the drug in the body. And it certainly would probably influence the way that you administered a drug, and of course in shock most drugs are administered intravenously. Our next point is going to be related to drug ionization. And first thing you have to ask yourself is this an important point? Is this something that I really need to know? And I'll just give you a tip here that most drugs have groups that can be ionized. And this is probably around 80 to 85% of all drugs have this particular property, that they can be ionized. So when you think about ionization, it clearly applies to most of our drugs. The concept basically says this, that most drugs are either weak acids or weak bases. And those weak acids or weak bases can exist in one of two forms, and I'm going to highlight those for you here. They're going to exist in either the non-ionized form, and you need to think about non-ionized as being non-charged or uncharged. Compare that to the ionized form, of course, which would be the charged form of the drug. Now, predicting how much drug is going to appear in either of those forms, you need to know the pH of the environment and the drug's pKa. So let's highlight both of those as well. The pH of the environment, you should be able to predict certain pHs, and I will give those to you as an example coming up very shortly. And then also when you think about drug pKa's, most often if the exam is going to want you to do anything with the concept of pKa, they're going to tell you the pKa of the drug. You just must use that knowledge to answer the question. And of course, by definition, the pKa is the pH at which the molecule is 50% ionized and 50% non-ionized. Again, to hit this point one more time, only the non-ionized form can cross membranes. In other words, charged molecules don't penetrate lipid bilayers very effectively. Now, it turns out that the ionized form is better excreted because it's more water soluble, and we're going to really take that concept and apply it because that could really be an important application on your exam. So in a nutshell, for weak acids and weak bases, the ionized is water soluble, the non-ionized form is lipid soluble. When we illustrate the concept of ionization, we really have to think about the relationship that exists between the non-ionized form and the ionized form of weak acids and weak bases. So I would really encourage studying and learning and memorizing really these relationships that are shown here. In fact, when you think about weak acids, there are a number of very important weak acid drugs in the body. I'm not going to list all of them certainly, but I'm going to give you a short list of some very important weak acid drugs. And if we start this list off here with one of your favorites, aspirin, that one is probably the easiest one to remember, right? What's the other name for aspirin? That would be acetyl salicylic acid. Pretty easy to remember that aspirin is a weak acid drug. But notice that some very important antibiotics, penicillins and cephalosporins, are also weak acids. Some very important diuretics like loops and thiazides are also weak acids. Now, each of these particular drugs and the fact that they're weak acids, we will cover these points later on in our notes, and we will refer to the fact that they're weak acids related to some potential drug interaction or some other property that would be useful for you. So this would be a good list of drugs to know that are weak acids. So when we look at a weak acid, you have to think about it in terms of a carboxyl group. If you like the chemistry, notice on the left side of the picture here, you've got a carboxyl group with a hydrogen attached to it. Notice that that form of the drug has no charge. That would be the non-ionized form of the drug. Therefore, that form can effectively and easily cross membranes. But if you take the hydrogen off of the drug, if you deprotonate the drug, you take that carboxyl group and you give it a negative charge. This would be the ionized form of the drug. The ionized form cannot move very effectively in the body, and therefore it is better cleared. When it comes to the weak base, again, there's also a list of important weak bases to know, and I'm going to give you some of those. Again, just a few examples to keep in mind. For example, morphine is a weak base. All of the local anesthetics are weak bases, all of the canes, if you think about those guys. And that's a very important point related to their mechanism of action, something that you will cover later on in the CNS section. How about amphetamines and PCP? And you may be thinking potential drugs of abuse here. The fact that they're weak bases may actually allow you to predict a strategy to help eliminate those types of drugs. So when it comes to the weak base, notice that on the left side of the figure here, you've got an amine group that has a positive charge, the RNH3+ form of the drug. Of course, that's the ionized form, so it does not move very easily in the body, and in fact, it's better cleared because it's more water soluble. On the right side of the picture, you've got the RNH2, which is the amine group with no charge. It's been deprotonated, so this is the non-ionized form of the drug, a form that can easily move within the body and easily cross membranes. And if you're not a big fan of chemistry, let me show you a kind of a shorthand way of remembering this. You can basically take the carboxyl group and turn it into A for acid, so that the non-ionized form of the acid is the HA form. Okay? If you take the hydrogen off of the drug, it's in the A- form. Again, it's just a shorthand way to write the same point out. If you're a big fan of chemistry, then go ahead and write out your carboxyl groups. When it comes to weak bases, again, B for base instead of the amine group, but once again a hydrogen is attached to the drug and that gives it a positive charge. So the BH+ form, the ionized form on the left, the B form on the right, which is the non-ionized form of the drug. Again, when you think about this, the left side of our picture here is what's going to happen in an acidic environment. When you take one of these drugs, either a weak acid or a weak base, and put it into an acidic environment where you have lots of hydrogens, you're going to attach those hydrogens to the drug, whether it be an acid or a base. But if you move those drugs into an environment that is less acidic, you're going to be more likely to remove the hydrogens from the drug. And obviously for an acid that makes it ionized, and for a base that makes it non-ionized. So spend some time on this picture until you know those relationships. Now what this diagram will allow us to do is to apply the things that we know. What's scary about this picture, if there's such a thing, is that it's our first graph, and some of you may have a fear of graphs, and I would encourage you, if that's the case, to spend some time looking at your axes. Now what worries you first of all about the x-axis here is that you have an x-axis with a calculation on it, right? pH minus pKa. But think about that calculation for a minute. If you know the pH of the environment, and you know the drug's pKa, and you do this calculation, and you come up with a negative number, what does that really mean? What does that tell you if pH minus pKa is a negative number? Well, that means you're going to fall on the left side of this graph, and that means obviously that pH is lower than pKa, and we would define that as an acidic environment. What if you did this calculation and you got a positive number? Clearly that means that the pH is greater than the pKa, and we would define that as a basic environment. Okay? So essentially what we've done now is we've divided our graph into two parts, an acidic side on the left and a basic side on the right. Now the first y-axis that we're looking at, the percent non-ionized form. If we follow this curve here for the weak acid, I would encourage you to label the forms of the drug that are going to exist in these different environments. So for a weak acid, it's going to be the carboxyl group with a hydrogen attached to it. The so-called HA form is going to be at the top of this curve. Because if you take an acid drug and put it into an acid environment, you're going to protonate that drug. You're going to attach a hydrogen to it. And that drug is going to be highly non-ionized. And what does that mean? That means the drug is going to easily move within the body. Okay? Now, as you follow the curve, you're going to move eventually to the weak acid form where the hydrogen has been removed. That would be the COO minus form of the drug. Now, if you think about this, what is really changing as we go from this form of the drug to this form? Is it the drug's pKa or is it the pH of the environment? And you should be saying it's the pH. Because if you look at your x-axis one more time, what is changing as you move left to right is that you're increasing the pH. And if you want a visual analogy of this, imagine a drug moving from the stomach towards the small intestine. And this is exactly what happens as the pH goes up. You're going to see that acid drug convert to an ionized form. You'll notice that we cross a midpoint here. You'll cross a midpoint where pH minus pKa gives us 0. Okay? If you do that calculation and you get 0, clearly the pH is equal to the pKa. And in that case, 50% of the drug is non-ionized and 50% of the drug is ionized. You can also do the same thing with the weak base. If you start on the left side here, label the form of the weak base that exists in this particular environment. The form that's going to exist there, the NH3 plus form, or the BH plus if you'd prefer. Notice that you're still going to attach the hydrogen in an acidic environment, and that's going to be the ionized form. So on the y-axis here on the left, the percent non-ionized is very, very low. Again, if we increase the pH, we're going to move to a form that looks like this, the NH2, which is the non-ionized form of the drug. Of course, this form can very easily move within the body because it's highly non-ionized. Then we've got the concept of renal clearance as the second y-axis that we want to deal with here. And when it comes to renal clearance, the rule is basically this, that we more readily eliminate ionized form of the drug. So if you think about a weak acid, you want to think about what type of environment you want to put it in to eliminate it. If you want to eliminate a weak acid, you want to put that weak acid into a basic environment. Why? Because that makes the drug ionized. Okay? If you want to eliminate a weak base, you want to put the weak base obviously in an acidic environment. That makes the drug highly ionized and more easily cleared. So notice the arrow going down means the forms at the bottom of our graph are more easily cleared. So to summarize, if you want to absorb a drug, you want to put the drug in its like environment. For example, weak acid drugs like acidic environments to move easily and be absorbed. Same thing for a weak base. If you want to eliminate drugs, put them in their opposite environment. Put a weak acid in a basic environment, put a weak base in an acidic environment in order to eliminate them. To give you an example of how the exam might ask you a question related to ionization, you need to understand some normal body pHs first. I would imagine that most of you know these and are pretty comfortable with them. We know the stomach is very acidic, small intestine maybe slightly acidic depending on where you are, the blood 7.4, and the urine has a range usually of about 5 to 8. If you know those normal body pHs, you can make some predictions as far as what's going to happen to a drug. I will also encourage you to think about any ionization question that deals with pH and pKa by envisioning your pH scale on a 0 to 14 basis. Okay? Except this time, instead of using 7 as your classic divider for what's acidic and what's basic, we're going to use the drug's pKa as our divider. And the question is always going to tell you pKa. For example, what if it says the drug has a pKa of 5? What you want to do in that case is you want to draw yourself a line representing 5 on your pH scale. In essence, what that does is it divides the graph into 2 parts, which I'll indicate like this. You've got a part to the left side of the drug's pKa, and obviously a much bigger part here on the right side with a variety of pHs there. Now, what is this environment called, where you've got a pH lower than the drug's pKa? You should call that an acidic environment. And on the right-hand side, where the pH is above the pKa, that of course is going to be a basic environment. If you can do that, you've gone a long way towards being able to answer a question related to ionization. Of course, the next thing that you have to do is to envision the forms of the drug that are going to exist. Let's say that this drug, in this example, is a weak acid. What form is going to exist on the left side of this picture? And of course, you should say it's the HA form, or the COOH form of the drug. Of course, that is the non-ionized form. And on the right side, if you take that weak acid drug and put it into a basic environment, the proton is going to come off, and you're going to be left with the A- form as the predominant form in the right side of this picture. What if this happened to be a weak base? Just for example, on the left side of our picture, you know that's going to be the BH plus form of the drug. If you then move that drug into a more of a basic environment, the hydrogen comes off, and there you've got the non-ionized B form of the drug. Okay? Again, this will help you answer these types of questions. And let me just give you a couple of samples here. For example, if you had a drug that was a weak acid and it had a pKa of 5, is that drug going to be more effectively absorbed in the stomach or the small intestine? Well, you should recognize that in the stomach, which is on the left side of our picture here, very acidic, this is going to be the predominant form of the weak acid. That form easily moves and will easily be absorbed. Okay? If you put that weak acid drug in the small intestine, which is going to be a little higher on our pH scale, it's more likely that this will be the major form of the drug, and that form won't easily cross membranes and be absorbed. Of course, if you wanted to eliminate that weak acid, it's pretty clear that you want to increase the pH to put the drug more in the ionized form. So again, you can use this particular diagram as a sample for any question that you get related to ionization. Draw this out, or at least visualize this as you're trying to answer that question. Next, we're going to review what ionization does to renal clearance. A couple of rules for you on this is that only the free unbound drug is filtered. Remember that we don't filter drugs bound to plasma protein, certainly not normally. However, if there's a point that's very, very important here, and I would argue one that students tend to forget, it's this point right here, that both the ionized and the non-ionized forms are filtered. Okay? We somehow tend to think that only the non-ionized form can be filtered, but notice that both forms can be filtered at the glomerulus. However, it's only the non-ionized form that can undergo active secretion and reabsorption. Okay? Why? Think about that. That's because those processes involve moving across membranes. Therefore, we refer to the ionized form of the drug as being trapped or stuck in the filtrate. The other 2 points here I'm going to blow up on this slide because they're very, very important for you on your exam, because this relates to eliminating drugs and possible strategies in a drug overdose situation. So, when would you want to acidify the urine? Of course, you should be saying if someone overdosed on a weak base. And if you want to use an example of some drugs that we've already reviewed now, the clinical vignette here would be amphetamines and PCP. If someone overdosed on amphetamines or PCP, what's a strategy you could use to enhance their elimination? And of course, the answer there is to acidify the urine. While there are several things you could use to acidify the urine, if you'll look in your clinical correlate there, it says to change urinary pH. If you want to acidify, I would encourage you to highlight ammonium chloride. Okay? Ammonium chloride can be considered really a non-specific antidote for weak base overdose. Okay? Certainly it's not the only thing that you could use, but that would be a good drug to know, a good chemical to know that is going to acidify the urine. And then the same thing when you think about alkalinization of the urine. That would be the case if you overdosed on a weak acid. And what's a popular weak acid? Mainly because it comes in such large quantities and you can get it so conveniently, you might think about aspirin. Okay? Someone overdoses on aspirin, you need to ask yourself, is there a specific antidote for aspirin? And the answer to that is no, there's no specific antidote. It's one of those things that distinguishes aspirin from acetaminophen, for example, which does have a specific antidote, you might remember, in acetylcysteine. But for aspirin, we don't have such a thing. So what you might remember is that this drug is a weak acid. And the strategy that you're going to use there is to alkalinize the urine. And if you go to your clinical correlate again, there I would highlight sodium bicarbonate. Okay? Sodium bicarbonate, very effective at alkalinizing the urine, which is going to facilitate the elimination of weak acids. One more time, why? Because you're raising the pH. If you raise the pH of the urine, you're going to put aspirin into the ionized form and you're more readily going to eliminate it. Now you'll also notice that to alkalinize the urine, classically or historically, acetazolamide has been used. And just to give you some information, remind you about that drug. Of course, that's a drug that's going to inhibit the enzyme carbonic anhydrase. And when you inhibit that enzyme, you're going to dramatically reduce the absorption of bicarbonate in the urine. All that bicarbonate in the urine is going to serve to raise urine pH. A clinical vignette related to this concept is one on hepatic encephalopathy. When you think about hepatic encephalopathy, you might think about severe liver disease. You might think about the impaired function that goes along with that. You might think about increased production of ammonia in hepatic encephalopathy, and you can use the drug lactulose in hepatic encephalopathy. And what's going to happen is that lactulose is going to be converted to lactic acid by gut bacteria. And essentially what's going to happen is that's going to result in trapping of the ammonia that's being produced. And the process is shown here, that ultimately lactulose is going to trap ammonia in the form of ammonium. And in that process, you're going to dramatically decrease the circulating levels of ammonia in the body and thereby be of benefit in hepatic encephalopathy. So it's a related vignette because you're talking also in this case about converting ammonia to ammonium. You're acidifying in order to detoxify, in this case, ammonia production. If you like visuals, this is a great diagram showing you renal clearance of a drug. And you start here with filtration at the glomerulus. Remember that it's only the free drug that gets filtered, okay? Unbound to plasma protein, because drugs bound to plasma protein are too large to get by, to get filtered here. Notice this, that both the ionized and the non-ionized form of the drug get filtered. Okay? Both can get in, but the difference is once they get inside. The ionized form, of course, is trapped. It cannot cross membranes effectively, so in essence, it is likely to be excreted. The non-ionized form, however, is able to cross membranes, so it is the form that's going to undergo the processes of secretion and reabsorption. Okay, so very important visual there for you. Remember, both forms can get filtered. Kind of a summary of what the glomerulus is like is that it's a good size filter, but it's a poor charge filter. Again, to remind you about the size, right, the fact that the drugs bound to plasma proteins don't get filtered, but a poor charge filter because both ionized and non-ionized forms can be filtered. When it comes to drug transport, again, this is kind of a reminder of transport mechanisms you probably have reviewed in physiology. There are three basic mechanisms: passive diffusion, facilitated diffusion, and active transport. And this applies for drugs as well, that each of these mechanisms can be utilized by drugs. But really, it's passive diffusion that is most often used. Remember, drugs move down their concentration gradient. They don't require energy, they don't require a carrier, and since there's no carrier involved, the system here is not saturable. Okay? There are only a few examples of drugs moving by facilitated diffusion. Remember, this is where the drug moves down its gradient. It does not require energy, but it does require a carrier. And since it requires a carrier, the system can be saturable. Also, only a few examples of drugs moving by active transport. And one example of that we'll refer to later on in our notes, is the tubular secretion of penicillins and also of diuretics. Simply the ability of those drugs to be secreted, for example, in the proximal tubule, which is where this is taking place. Since it's active transport, it's against the concentration gradient. It does require energy. Okay? It does utilize a carrier, and that system is definitely saturable. I'm going to do a little tie-in here, which shows you that any system which utilizes a carrier, of course, is saturable. Okay? Systems that utilize a carrier can be saturated, so facilitated diffusion and active transport.